Just remember to keep it natural, keep it light, keep the flow going. If you do need to pause, just remember your 5 seconds. I'm going to start a 5-second countdown. I'm going to start at 5, and then I'm going to disappear. If you can continue counting in 5 in your head, and then start from when you get to 0, please. You're good with that?
Just repeat that, please. You're going to count down to 5?
No, I'm going to start. I'm going to say 5, and then from 5, if you can count down to 0 in your head,
Yes.
and then start.
Okay. All right.
Okay. Good luck. Enjoy it. Have fun. And in 5.
Okay. Thank you. Good day, ladies and gentlemen. I'm Ilsbae Spoelstra from South Africa. I'm going to talk about supplemental parenteral nutrition, which we call SPN. And today the question is, does SPN really matter? I have a conflict of interest, and now I'm going to tell you why am I in favor of using SPN. I'm a critical care dietitian for the past 24 years in a private hospital. I had the honor to learn about SPN from Professor Matar from Cairo, but also many others. I was one of the first critical care dietitians who implemented SPN, and I don't know how I would feed my patients successfully without it, especially in the past 18 months of COVID-19. There you can see Professor Matar, and he says, "We know much, we apply little." This quote inspired me greatly. So let's see, what is supplemental parenteral nutrition? It is the addition of parenteral nutrition to enteral nutrition and or oral nutrition to achieve nutritional goals, that is calorie and protein targets, whenever the patient is not able to meet more than 60% by enteral and or oral route. I'm reporting results of SPN in studies. Now first I need to mention Professor Paul Wischmeyer. He says SPN does not pose an infection risk. On the photo we see Professor Wischmeyer, and we also see the father of parenteral nutrition next to him. Wen Bin Yang, SPN can improve caloric and protein intakes, shorten the duration of mechanical ventilation, shorten the length of stay in ICU and in hospital. He also said that SPN reduces the incidences of infection complications without apparent impact on blood lipid and sugar profiles or liver or kidney functions. And after treatment, the albumin level was also significantly higher in the SPN group than in the enteral nutrition group. Lorenzo Pradelli and the others say a significant cost reduction was found with SPN, suggesting that optimization of energy provision using SPN is a cost-effective strategy in selected critical ill adults. Ricardo Cachalanza says the international guidelines recommend the use of SPN in cancer patients when they are malnourished and hypophagic, and where enteral nutrition is not feasible. In the same study, early 7-day SPN resulted in improved body composition, in improved hand grip strength, improved serum prealbumin levels in hypophagic and hospitalized cancer patients at nutritional risk in the absence of any relevant clinical complications. Sunish Shah says, or actually asks, when is parenteral nutrition appropriate? Consensus recommendations suggest initiating parenteral nutrition after 7 days for well-nourished, stable patients, within 3 to 5 days in those who are nutritionally at risk, and as soon as feasible in those with baseline moderate or severe malnutrition if oral intake or enteral nutrition is not possible or sufficient. Shaw says critically ill obese patients may be a nutritionally at-risk population warranting earlier parenteral nutrition initiation. Then SPN in COVID-19. I really don't know how I would affect my COVID patients if I had not had SPN. If a patient is on non-invasive positive pressure ventilation, they have no appetite, they can't eat because of the low oxygen levels, it is not possible to place a tube, and then the only way to feed them is to supply SIP feeds combined with SPN. Regarding the gastric residual volume, there's no clear answer to this question. We cannot say don't do GRV. But Professor Elizabeth de Walle mentioned at SPN 2020 and 2021 that they do not do GRV in their ICU. In the critically ill COVID patient, it is safer to combine SPN with a lower volume of enteral nutrition to prevent aspiration. I did see aspiration in patients on full enteral nutrition. That was COVID patients. Professor Wischmeyer always stresses that our patient becomes hypermetabolic, especially later in the disease, so we should use SPN to add up the shortage. What is important is the international recommendations on nutrition in the ICU should always be followed. Autophagy should be taken into consideration also in COVID-19 patients, but let us use the results of the studies, feed our patients optimally, and achieve good outcomes. So I'm going to present a case study on the management of preoperative malnutrition by using SPN. Our patient is Mrs. T.K. She's a 59-year-old female. She had gastric bypass surgery 20 years ago. She's on chronic hemodialysis. She was admitted with intermittent bowel obstruction and biliary colic. She had a total protein of 59, an albumin of 22 millimole per liter, which is 2.2 gram per deciliter. Her appetite was healthy and she was able to finish a proper meal. But she presented with weakness. She couldn't stand for more than 15 minutes and she had severe abdominal pain. So the surgeon had to undo the bypass surgery. He referred her for nutrition therapy with the instruction that the albumin should reach a level of 30 millimole per liter and she should be in an acceptable nutritional condition prior to surgery. I just want to mention this case is not about albumin. It is about severe malnutrition. It is about the management of the patient and to get her in a better nutritional status prior to surgery and after surgery. So since she was eating fairly well, her nutritional status and serum albumin is suspected to be low due to previous bypass surgery, suboptimal absorption, chronic hemodialysis, and insufficient dietary protein. So what approach would we use? Would we start SPN, administer Albisol, supply a very high protein diet, or prescribe high protein SIP feeds? Well, out of the history, we know that the only way to go was to start SPN. So it was decided to supplement her intake with parenteral nutrition with the aim to improve her nutritional status. Parenteral nutrition was provided. It was 84 gram protein, 161 gram carbohydrate, 80 gram fat, 1769 kilocal, and the rest of the protein, the calories, were provided by soft foods and semi-elemental SIP feeds. On day 8 preoperatively, the surgeon had to decide about the surgery. The patient was feeling stronger and could walk further, but the albumin was not at 30 and the specialist physician insisted the albumin at 30 millimole per liter. She said that the patient would die if we operate at that stage. So the surgeon decided against the surgery. He gave me another week to help patient. I thus intensified my feeding strategy. SPN continued, and I only used semi-elemental sip feeds. On day 18, the surgeon argued that if he does not operate, she will die anyway because of a deteriorating condition of the gallbladder. So he decided to book the theatre. On day 25, she was taken to theatre. She survived surgery. She had a CRP of 283 on the day after surgery. She was extremely ill, and the surgeon's preference for feeding was parenteral nutrition. Now, between day 26 and day 72, there were many ups and downs. A lot happened, like desaturation, intubation, bowel distension, nausea and vomiting, diarrhea, no tolerance of enteral nutrition, CRP fluctuations, and she was extremely ill. So parenteral nutrition was continued. A high nitrogen semi-elemental feed was eventually started at 20 milliliter per hour, so SPN had to continue. Micronutrients were also administered. By day 73, the patient started slowly on a full fluid diet. By day 75, the CRP was 82.5. We could stop all IV feeds. We continued enteral feeds, and a soft diet and renal-friendly sip feeds were started. There you can see our patient still in ICU, but much better. On day 83, the patient was discharged from ICU and into the ward. After a total of 89 days in hospital, she was discharged to a step-down facility on a renal-friendly diet. Wasn't it for SPN, I surely would not be able to do my nutrition therapy successful. So there is a happy ending. Currently, she's back to full-time work with a good quality of life. So SPN was a lifesaver in this beautiful woman. Thank you.
Excellent. Excellent.
Wow. One hit wonder.
Yeah, exactly.
Ja, well done, Ilsbae.
Hoe dit gevoel, Ilsbae?
Ek het of aan nie.
Ja.
Ja, ek dink mense is maar senuweesrig, maar as julle sê dis goed, dan sê ek dankie.
Daar was geen fout aan my kant nie. Jackie, there was no quality. Can you guys hear me?
Yes, we can. We can hear you.
Yes, we can.
Yeah.
Okay.
No quality issues. I was watching on the other channel. All good. All good.
Yes.
Absolutely no glitches. Just
Yeah.
no ums, no ahs. Just
Yeah, exactly. And the flow in the presentation was great. We could follow exactly. And I think from the slides that you presented, obviously I would love to get the updated one with the pictures in, because the one I've got doesn't have any pictures.
Yes.
And ek dink ons sal lekker kan werk met die bullet points en om 'n paar goedjies lekker in te bring dat dit jou praatjie komplementeer.
Okay, baie dankie.
Lisa Marie, is julle happy? Want ek dink there's nothing to improve.
Yeah, but I think Jack, you said it, one hit wonder.
Ja. Nee, dit was so natuurlik. Dit was regtig great, Ilsbae. Regtig.
Okay, dankbaar.
Goeie voorbereiding daar.
Nee, baie nice. Dankie vir die tyd en moeite. Ek weet is baie tyd wat ingesit is, hoor.
Ag, baie dankie vir julle.
Great.
Right. Thank you, Jackie.
Then we good to go.
Awesome. Thank you. Bye, dankie.
Okay. Thank you, Jackie.
Nou is jy nog vars genoeg vir ICU vanmiddag.
Oh, no.
Save another life.
They can go on without me today.
Wonderful. Okay, well, dankie ladies. That's it.
Thank you
Mag
very
julle 'n
much.
lekker lang naweek hê vir almal.
Dankie.
Dankie selfde. Tada. Bye.
Bye.
Bye-bye.
Bye.